Welcome. Thank you for joining us today. My name is Janice Butchko, Senior Project Manager for the MDS Foundation. Also joining me is Ashley Moncrief, Director of Patient Care. We will be moderating today's webinar. Thank you to our sponsors for supporting this webinar program: AbbVie, Bristol Myers Squibb, Taiyo Oncology, and Servier. Please note, this is a pre-recorded presentation, so the presenter will not be taking any questions. The live question with answer segment for all participants are included at the end of this presentation. Today's presenter is Dr. Andrew Brunner. Dr. Brunner is an assistant in medicine in the Division of Hematology and Oncology at Massachusetts General Hospital Cancer Center, an assistant professor at Harvard Medical School, both in Boston. He earned his medical degree from Brown University and completed an internal medicine residency at Massachusetts General Hospital before completing a hematology oncology fellowship in the Dana-Farber Partners Cancer Care Fellowship. He is board certified in medical oncology and in internal medicine. Dr. Brunner's clinical focus is for the treatment of patients with myelodysplastic syndromes and acute myeloid leukemia, as well as other cancers of the blood and bone marrow. His research focuses on the development of novel therapeutic strategies, typically phase 1 and 2 clinical trials for patients with MDS and AML. He has been involved in studies that explore unique targets in these cancers, including mutations in the spliceosome or targets expressed on immune effector cells. At the same time, he researches patient outcomes in MDS, including ways to better understand why certain patients have better responses to treatment than others, and which treatment responses are more meaningful to patients. Overall, he seeks to discover novel treatments in MDS, which improves survival and patient quality of life. He receives funding support from the Edwards P. Evans Foundation to support his career as an innovative clinical translational investigator in MDS. It is my pleasure to introduce Dr. Andrew Brunner.
Hello, my name is Andy Brunner. I am an oncologist at Massachusetts General Hospital, and I am here today to talk about recent updates on the MDS classification system, with a particular emphasis on how that might impact our clinical management of patients who have MDS. It's a pleasure to be here and look forward to chatting with you today. MDS is a disease that happens as we age. It's really an umbrella of different blood cancers that is most prevalent in people in their 60s, 70s, 80s, slightly more common among men than women. And there can be a real variable trajectory with MDS. Some patients will have a course that really causes problems to them within months of being diagnosed, whereas other people will really live with it almost as a chronic condition, and it can take years before they may even need intervention. And a lot of what we do when we meet somebody with MDS is we try to figure out what exact type it is. And a lot of that goes into how we evaluate MDS diagnostically. And so one of the things that we are thinking about when I meet a patient with MDS or meet a patient who there's concern for that is this idea that they have low blood counts, and we don't know why that is yet often. And we're trying to distinguish whether there are causes related to environmental exposures, medications, nutritional deficiencies that are causing low blood counts that are not cancerous, or do patients have some degree of blood cancer, chronic one, but that's contributing to the low blood counts that we see, and that manifest as symptoms of fatigue or of recurring infections or of bleeding issues. And how do we distinguish this disease, this diagnosis, not only within MDS, but from other causes of low blood counts? And those can include subtypes of disease that have a clonality, meaning that there's some mutation that has happened in the stem cell, but may not be the whole contributor or may not meet criteria for MDS yet. Those are conditions like CHIP or CCUS, CCUS. And then also distinguishing from other blood cancers, acute myeloid leukemia, chronic myelomonocytic leukemia, myeloproliferative neoplasms. And so there are a lot of ways that when somebody shows up and they have a low blood count, we're really thinking, well, what is driving this? What is causing this? Because that also helps us figure out how to treat it. And again, I think that one of the things that we've learned over time is that really MDS represents this large spectrum of disease and really of different diseases almost. There's a common name for them in MDS, but even within MDS, we have a lot of different subtypes of disease, and each of these has a different flavor. And I think that it's important as a patient or as somebody who's dealing with MDS to understand not only what type there is, but then how does that, what's the natural course that usually causes. And so MDS can be characterized by what we see in the bone marrow. So what kind of cells are there, what kind of mutations are present in those cells. Different types of MDS will have different variations in blood counts. So some types of MDS, like MDS with an isolated mutation in SF3B1, most typically will only have a slowly progressive anemia as the cause, as the problem with its disease. MDS with deletion of 5q, if there's not other abnormalities. Similarly, patients develop an anemia, may have a high platelet count, and they have a very particular course to their disease. In contrast, there are some types of MDS where the blast count is higher and they are often associated with more rapid progression or more need to manage the disease more urgently. And so when we are making a diagnosis in MDS, we're really looking at three elements. Do patients have low blood counts, ineffective hematopoiesis? So you have to have some sort of low blood count. You have to have a problem that your bone marrow is not making enough blood. Is there evidence of dysplasia? So dysplasia usually indicates that the bone marrow is not producing blood correctly. And the types of dysplasia that we see change what kind of subclassification that we might give an MDS diagnosis. And then last, we want to know whether this is clonal, meaning that there is a common origin for these cells. Usually clonality can be defined through acquired mutations or through chromosomal abnormalities. And we often are thinking about how patients with MDS will have an expansion of a clonal population over time, and that population is the one that's making blood and not doing a very good job of it. It's part of why the blood counts are low, and it's part of why people have complications from disease. And so to start out in the diagnosis and get that subclassification of disease, we'll start out with a bone marrow biopsy. Most people will present with fatigue or infections or bleeding complications and be found to have a low blood count. And that could be the white blood cells or the neutrophils. That could be a low platelet count. Most commonly is going to be an anemia. So patients will have an anemia that's not explained by bleeding or blood loss, not explained by a nutritional deficiency. And at some point, once the obvious causes in blood work don't show any etiology or something to fix, we have to think about doing a bone marrow biopsy. And a bone marrow biopsy is still the mainstay by which we will identify diagnosis of MDS and be able to subclassify it further. On a bone marrow biopsy, we can get some things that we can see also with blood. So, you need to see whether there are low blood counts. You can get some testing is pretty accurate on the blood as well as the bone marrow, like molecular testing increasingly seems like it can be done on the blood and bone marrow. But there are some things that the bone marrow provides that are really unique to that space. So the percentage of blasts in the bone marrow, for instance, may not mirror what is seen in the blood. Similarly, ring sideroblasts are better identified in a bone marrow sample. And then the full chromosome assay, karyotype, really a bone marrow sample is better at reporting that than using peripheral blood. So when we do a bone marrow biopsy, you can, most people are either lying on their belly or on their side. They can be done, we do them in our offices. Sometimes they're done in radiology, but they're trying to collect two samples. One is a liquid part of the bone marrow. The liquid part allows us to look at what kind of cells are present. And then the other is a solid tube of the bone marrow, a core biopsy. And together, these allow us to get a better picture of what's going on in the bone marrow. Why are you not making enough blood? Is there something structurally abnormal in the bone marrow? Is there something that, we really need to further interrogate? And so the liquid part in particular will show us the number of blast cells. Normal bone marrows have a low number. As you get dysplasia and you get mutations in the cells, sometimes the blasts will start to build up and crowd out other cells. We're able to stain it for iron, and we can look at ring sideroblasts, which are also reflective of usually abnormal red cell production and associated with certain mutations. And then we can look for dysplastic features, dysplasia where we see abnormal appearing cells or cells that aren't maturing correctly or stuck in that blast phase. So here's an example of one of the things that we might find on a bone marrow sample. You can see we've stained this sample with an iron stain that shows these little blue balls circling around the nucleus of the red cells. So that ring of blue balls or ring of iron deposits, it drives the name of these ring sideroblasts. And so this would be can be seen outside of MDS due to other causes, but most commonly is seen in MDS, particularly with an SF3B1 mutation. It is how we get this prior term of sideroblastic anemia. And so it does help us define a subset, and it's a very quick thing that's done on the bone marrow to help us say, this is the type of MDS with these ring sideroblasts, and it has some treatment implications sometimes as well. Similarly, we can use the bone marrow sample to look and see how many early cells, stem cells, are there, blast cells. We all should have stem cells in our bone marrow, but when cells acquire mutations and start to develop into MDS, the blast cells sometimes will also expand in number. It's kind of a sign that the bone marrow is not working very well. It's not able to mature cells appropriately. And so the number of cells in the bone marrow, blast cells, start to expand, increases the proportion of the bone marrow. And so that can be an abnormal finding that can give us a sense of, yes, this is clonal. Yes, the bone marrow is not functioning normally, and can give us some implications into risk as well. You can also see the cellularity of the bone marrow. So you can see over here, there's a core biopsy sample. And in that biopsy, you can see how the number of cells in there is essentially 100% nearly. The whole bone marrow is full of cells. Normally, as we age, the number of cells in the bone marrow will actually decrease. So if I'm 60 years old, I would expect only about 40% of the bone marrow to be cellular. And so seeing this number of cells kind of illustrates how bone marrow is really trying to make blood. It's just not doing a very good job. And hypercellularity is pretty common in MDS. And then the other main thing that we'll see that can be seen in the peripheral blood as well, but often the bone marrow can illustrate it more overtly, is any evidence of dysplasia. So what is dysplasia? Most cells in a healthy bone marrow, we know should look a certain way at each stage of their maturation as they're growing up, going from blast cells or infants into childhood cells, and then teenager cells in the bone marrow. They should all look a certain way until they grow mature enough to enter our blood. And when you see abnormalities in that maturation, that can sometimes be due to a toxin, medication exposure. It can be due to severe illness. But when it's not due to something else stressing the bone marrow, it often can be a hallmark of MDS. And really, we want to see that there's a certain amount of dysplasia to make a firm diagnosis of MDS. That diagnosis is important because the dysplastic features that we see really reflect the abnormal blood production that has happened by the time somebody gets a diagnosis of MDS. So here you can see some abnormal red cells where instead of having normal round nuclei, they've got these blebs and irregularities of the nucleus, kind of showing how they're not following a normal maturation process. They're not growing up normally. They're having trouble, and that often then reflects low blood counts in the blood. And so we use these three elements, dysplasia, clonality, ineffective hematopoiesis, to make a diagnosis of MDS. But then we want to further understand and classify what kind of disease is this? Because again, not all MDS is the same. And the big advance that we've had in the last 10 to 20 years is really a much better understanding of how genetics impacts MDS diagnosis and how we should group diseases based on their genetic features. And that gets into this idea of clonality. You know, we think that MDS happens. There's some mutation that happens in a stem cell that may not cause MDS in and of itself, but that over time, that mutation gives that cell a growth advantage. Perhaps other mutations occur, and that population of cells with those mutants in it start to expand and increase and become more and more of the blood. And so defining that clonality, understanding what mutations are present in MDS gives a lot of understanding of what type of disease you're dealing with. And so one of the things that we want to do on a bone marrow, and we mentioned earlier, is this full karyotype. So we do chromosome testing. You can see, you can lay out, each of us has 46 chromosomes, 23 from each parent. And so they're all in pairs. And so you can see here that this chromosome, they line up the pairs, but there's some pieces of the chromosomes that are missing. Some have migrated to other chromosomes. So you can get a sense of what has happened to these cells to cause the MDS. And these are large structural changes in the chromosomes. At the same time, we can also do specific mutation testing. So there's a number of genes that have been identified that, for whatever reason, these are certain gene mutations that don't kill the cell entirely and allow it to persist and may give it ability to expand and have a growth advantage over healthy stem cells in the bone marrow. And so using these elements, we can get a better sense of what mutations have happened. You can do this testing also on the blood. So there's a lot of testing that we can do where we take sequencing off of blood cells, and you can similarly identify whether there's a clonal abnormality in the blood that might be leading to the low blood count. But all of this has really advanced a long way of our understanding of what drives MDS, why do people get MDS, and then how do we use all this new genetic information in addition to features of the blood counts and of the appearance of the bone marrow How do we use those three elements to try to say, this is one type of MDS, here's what you should expect with it. Here's another type of MDS, here's what you should expect with it. A lot of it's kind of like a foreign language in some ways. How do you communicate about a disease? For many patients, right, knowing what subtype of MDS and what kind of risk you have as well is one of the ways that you can understand and talk about disease with other people. So if I have MDS that is lower risk and it has ring sideroblasts and I only have anemia, it can be really informative to talk to people who have that same kind of disease to understand what to expect from it. Similarly, if I have MDS with low risk and only anemia, but I'm talking to people whose MDS maybe has a lot higher risk, or maybe they have a lot more complications of their disease, they may not have the same treatment goals or treatment therapies as I do, and so it may not be as useful necessarily to try to understand my disease if I'm talking to someone who doesn't have the same type. And so this is ongoing understanding for many, many decades, was this need to kind of standardize how we talk about different types of MDS. So that whether you're on the doctor side trying to treat a patient, whether you're on the academic side trying to understand outcomes or trying to identify new therapies, or if you're a patient and you're trying to understand what does my disease mean, there has been a long evolution of how MDS has been classified. So here's kind of a background overview of how, really over the last 100 years, MDS has come to be known as a clonal disease. So, for a long time, the distinction of MDS, before we had genetic testing, we would distinguish MDS from AML by having lower blast counts. So acute leukemias appeared different. And then also MDS had to be distinguished from other non-cancerous causes of low blood counts. So usually anemia. And since there's mostly anemia, it received a number of terms, including refractory anemia, meaning essentially that we couldn't find another cause, a secondary cause. Eventually, it was classified, and it started out with the FAB classification, which was then updated and eventually incorporated as the WHO classification in 2001. And this created this spectrum of disease that really still lives today. Was updated in 2008, and then most recent was updated in 2016 and 2022. And these updates each time reflect a little bit better understanding of the disease, of what to expect for each subtype, and also of just, if I'm a patient with MDS, what is the natural course of this? One of the things that we knew early on was that different subtypes of MDS, this is the FAB classification, have different clinical courses. So patients who had only anemia, this was before we really knew the genetics of that disease, but refractory anemia with ring sideroblasts, they tended to live with just anemia for a long time. Whereas patients who had increased blasts or were bordering on acute leukemia, they would have more active disease problems. They would need more active management early on. There was also a difference in the chance of disease staying stable, meaning just being MDS, or disease progressing to an acute leukemia. And that could be seen within the classifications. And the 2016 classification is interesting in that it does really start to show how genetics has entered the playing field, and our increasing understanding of the importance of molecular diagnostics and chromosomes to distinguish MDS and distinguish it within subtypes of it, but also distinguish it from other blood cancers. And I'll point out here, for instance, refractory anemia with ring sideroblasts, it was found that really SF3B1, which is a gene that's mutated and is involved in splicing, that this was one of the main drivers of ring sideroblast formation. Similarly, MDS with a deletion of 5q had been understood as a kind of a unique entity clinically as well, and it was further refined in 2016. And so we had this group of disease classifications in 2016, MDS with single lineage dysplasia, multi-lineage dysplasia, MDS with ring sideroblasts, MDS with isolated del5q, MDS with excess blasts, and then if you couldn't fit one of those categories, you were defined as MDS unclassifiable. We have had some big updates in 2022. And I think that for an individual patient, these don't have a huge change in the disease course. They are more granular and they better reflect what we've understood about genetic alterations and their impact on disease course. But in the big picture, I think we are just getting better about talking about things that we already knew. And so for most patients, I don't think that these changes have a big real impact, although they do make the disease a little bit more confusing. And we're working hard in the field to try to make it less confusing. And I think that that is the next destination. But there are a lot of parallels between the WHO 2016 and the now two classification systems, WHO 2022 and ICC 2022. Again, a lot of this is so that everybody can communicate about the same thing. It's kind of like a Rosetta Stone here of what is your disease, and if I'm talking to someone or I'm trying to do a study or I'm trying to understand what kind of treatment to do, are we talking about the same entity? And so, for instance, in 2016, we had MDS with excess blast 1. That would be if you had a bone marrow biopsy showing 5 to 9% bone marrow blasts, or you could have an occasional blast in the blood. And in 2022, it's very similar. So MDS with increased blast 1 by the WHO, and the ICC calls it MDS with excess blasts. Both of them are pretty close to one another. It does make it a little bit of a challenge. Our institution reports often all three, WHO 2016, WHO 2022, and ICC 2022. And I think that is just a reflection that we want to be clear that we're communicating the same entity. And if you went to another practice with our pathology report, that it would be immediately understood. MDS with excess blast 2 in 2016 had 10 to 19% blasts. And in 2022, the WHO called that MDS with increased blast 2, while the ICC changed the name a little bit and called it MDS/AML. Practically speaking, I think we use blasts to define the difference between MDS and AML, AML being 20% or higher blasts, MDS being less than that. I don't know that the behavior of disease is too different, and we're still kind of describing the same entity. For those of us who are developing therapies, I think we think a lot about, okay, well, how do we deal with this group? Should we include them in AML trials or MDS trials? But that's not a new discussion. That's been something going on for a long time. And so, again, naming all three kind of helps to show that, these really are the same or similar entities. The other thing that's really changed in 2022 is the bigger recognition of molecular and cytogenetic abnormalities that just define a disease. And so AML defining genetics have a much clearer role in the 2022 classification systems. That includes a number of alterations that are disease defining. Similarly, MDS with TP53 mutation, the biallelic loss of P53 is increasingly understood as a poor prognostic feature. We also have a number of updates in our lower risk, or typically lower risk disease. So MDS with single lineage dysplasia, multi-lineage dysplasia, depending on the WHO or ICC, falls into this kind of similar group of disease where patients have low blast count. Similarly, there are patients who have a SF3B1 mutation, and those are more clearly defined than in the 2016, where ring sideroblast was the preferred term. Now MDS with the SF3B1 mutation is the preferred term. And why do these things matter? Well, we talked a little bit about SF3B1. We've increasingly understood that some of our therapies may work differently in certain mutation groups. So this is data from the COMMANDS trial comparing luspatercept to epoetin alpha in the frontline setting. And it showed that for patients who have an SF3B1 mutation compared to patients without an SF3B1 mutation, they really have a different response to luspatercept, whereas there is not as much of a difference for epoetin alpha. And so perhaps suggesting that, if we do have a difference in response, defining this group in our classification system differently may help with identifying people who are likely to benefit from a given therapy. Similarly, TP53, it's a challenging mutation group. It is increasingly understood that, while we make distinctions between MDS and AML for a lot of our disease, if you have a TP53 mutation, especially if you have biallelic, meaning two loss of both proteins in the gene in the MDS cells, MDS with TP53 mutations and AML with TP53 mutations seem to have fairly overlapping outcomes. So is that a way that we could improve perhaps our drug discovery for this group by combining all patients together to try to understand how to make their outcomes better? And then just to highlight how we are finding mutations that really should define disease as AML. If you look at NPM1, which historically we've thought of as it's more common in AML, but it never really trumped the blast count so much. However, increasingly it looks like if you have an NPM1 mutation in MDS, you respond better to AML-like regimens. So giving patients an AML-like treatment kind of supports this idea that maybe NPM1 mutant disease really should be in the AML category of disease, since it responds better to AML-like treatments. So here's just a case to kind of illustrate how classification happens in practice. See, an 83-year-old man came to his primary care doctor. He'd been having fatigue for about 6 months. Medical history is notable for some cardiovascular disease, generally well managed at this time. No personal family history of cancer. And on exam, on his labs, he has an anemia. He has a normal white blood cell count of 5, platelet count of 132, but he is anemic. His hemoglobin's 9.4, his hematocrit is 30. His large cells, MCV, is 105. And his other chemistries, he has some mild kidney disease, but his other chemistries look okay. He does have on his peripheral blood smear some dysplasia, so you can see this cell with a bilobed nucleus. You can also see erythroids in the blood, so you shouldn't be able to see nucleated erythroids in the blood in normal state. And so all of this making you suspicious that there might be something going on in the bone marrow. He has a bone marrow biopsy, and it comes back with a categorization based on morphology. So they say that he's got myelodysplastic syndrome. They see multi-lineage dysplasia and ring sideroblasts. So this would be using that would be that WHO 2016 criteria. So they see dysplasia in all the lineages. They see ring sideroblasts. We get that back fast, but we don't have karyotype or the molecular testing yet. There's no increase in blast. There's only 1% blast, and they see they'll stain it with an iron stain, and they see more than 15% ring sideroblasts. The mutation testing often comes back maybe a week later. This shows a single mutation in a gene SF3B1. And so this is the kind of report we get back, and then we get an amendment on our addendum on our path report. So what is this patient's diagnosis? So our pathology reports will show 3 classifications here. So I get MDS with ring sideroblasts, MDS with mutated SF3B1 by the ICC, and then by the WHO, we get MDS with low blasts and an SF3B1 mutation. And so when we talk to that patient, that's the way of describing their disease. We can understand what kind of to expect by this disease. But what does it mean? What implications does it have to the actual patient? Now, there is some association with the WHO 2022, as well as the WHO 2016 and ICC. Each of these subgroups has a bit of a trajectory. So you can see that depending on what classification, what diagnosis you have within MDS, there's a different expected course of, how stable do we think your disease will be? What's the likelihood that we think it will turn into leukemia? Or is this something that you're just going to live with versus is it going to cause more immediate dangers to you? But I think it is an important thing to note. And when you're talking about what type of MDS do I have, what classification do I have, that just making the diagnosis and subclassifying MDS is different from prognosis. So with all my patients, even though once we have done the bone marrow and get all their testing back, we can say what type, what classification of MDS they have. We still need to think differently about what does that mean for what to expect over the next months to years to come. And that's because it's not just the diagnostic subclassification that has impact on prognosis. It's a combination of the mutations present, the types of low blood counts that you have clinically, as well as the number of blasts that are in the bone marrow. And so we tend to use the IPSSM. This uses those 3 elements, so mutations and karyotype, the types and depth of low blood counts, and then the number of bone marrow blasts, and it integrates that to get a sense of what to expect over the years to come. Is this a type of MDS that you might just coexist with? Is this something that's going to be more actively managed in the next months? And give you a sense of using this web model. It gives you a sense of where you fall in the spectrum of MDS, centered around a hazard of 1. So the average person with MDS, do you have a higher risk that this will become a problem sooner? Meaning you move up on the ratio, up on your score, or do you have a lower risk, meaning that you're, compared to the average person, you're probably just going to live with this, and at some point the cytopenias will need to be managed. And so while indeed there is some general alignment of lower risk or higher risk disease with the subclassification of MDS, so lower risk disease tends to be MDS with low blasts, MDS with an SF3B1 or 5q deletion, MDS with ring sideroblasts. Those tend to fall into the lower risk groups. And similarly, MDS with increased blasts, MDS AML, MDS with mutant TP53 or with fibrosis, these tend to be higher risk subgroups. You still need to evaluate the risk and the prognosis somewhat separately, and often use those 2, what kind of disease you have with classification, and then what is your prognosis, to try to understand what's the best path forward for treatment. And so just to conclude, and decide to take any questions that I can, MDS classification systems have evolved, and they've evolved for the better. They better reflect our growing understanding of this spectrum of blood cancers. They also give us a real good sense of common clinical courses of disease. If you have one subtype of MDS, you can talk to other people with that subtype, and it's more relatable than if you're trying to talk to somebody who has a very vastly different type of MDS. The classifications allow us in the academic community, as patients or as doctors, we can better compare different disease subsets. And they may impact treatment selection. MDS with SF3B1 mutations may be better benefited from certain treatments. MDS with TP53 mutations may require a different approach altogether. MDS with del5Q has long been a subgroup of disease where lenalidomide for anemia is effective. And so I think, it's important that we've evolved our diagnostic classification over time. It's also important to remember that this may reflect somewhat the prognosis of your disease, but it's important to still do the IPSSM or IPSS or IPSSR, use a prognostic tool to further understand what's likely to happen for your disease. So again, I'd like to thank you for your time, and I'm happy to answer any questions.
Hi, my name is Ashley Moncrief, Director of Patient Care for the MDS Foundation. Just want to thank Dr. Brunner for such an excellent presentation. Really great job. So we will start with our question and answer segment. So please do list any questions that you may have in the Q&A section. So our first is, why is DDX41 not on the list?
Yeah, no, that's a great question. It is, so this is really the focus on the MDS subclassifications. DDX41 kind of fits into an umbrella where similar to kind of therapy-related disease or other familial risks for leukemias and MDS, there are certain germline mutations that are predisposed to many types of blood cancer. So that can include MDS, that can include AML. And so these umbrella terms kind of fall into familial predisposition, but they could be a subset of disease. So you could have DDX41 and then have AML. Similarly, you could have DDX41 and have MDS, and then you'd still kind of look at the MDS specifically within that group. There are some, this is kind of a good segue for familial myeloid neoplasia risk in general. It's often overlapping with the risk scores and the prognostic tools that we use, but there are some nuances, and DDX41, for instance, may not adhere perfectly to the risk scores that we use for other subtypes. And so it's important to find it. It matters for transplant. It matters for the overall goals of treatment. But it's kind of a additional classification that that goes along with the then specific disease subclassification.
Great. Our next question is, beyond the classifications, what are the other factors that help determine prognosis? I was diagnosed last year at age 56 with MDS SF3B1. It seems my disease journey as a younger woman would be very different from a 75-year-old man, for example.
Absolutely. Yeah, I think, all of these things are really tools to help us have a discussion with a patient who's facing this. And when somebody has a diagnosis of MDS, we're trying to determine how much is this going to matter in your life? When is it going to be a problem? And do we have appropriate tools to fix it, I guess? And you're right. If you're 56 and, we think you have 30, 40 years ahead of you, can you live with that bone marrow for the whole 40 years? And that's a different question than if you're in your 70s or 80s, or if you have other issues that are competing. And so some of that does come down to, okay, how stable is your MDS likely to be? Is it going to worsen into an acute leukemia? Are you going to start having problems from your disease within the next 1, 2, 3, 5 years? If so, should we act on it? And that's what our risk tools use. But at the same time, we also have to think about what your overall goal is. And treatment for MDS includes a growing number of therapies. Stem cell transplant is still our only curative therapy for MDS. And when someone says, well, how do I live 10, 20, 30 years from my diagnosis? Often that involves discussion around transplant at some point. Now, that is where the prognostic tool differs a little bit from the diagnostic, but MDS with SF3B1 often falls into that low risk group, but still you'd want to do an IPSSM or another risk stratification tool to figure that out. But even if it is low risk, at some point, the cumulative problems of disease will make the risk benefit decision around doing something like transplant make more sense to proceed. And there is some data that for high-risk disease, it makes sense to really discuss transplant early and think about doing it, if you have high-risk MDS within a few months of diagnosis, really. And for low-risk MDS, most people will live longer and without complications if you delay transplant until it's clear that you've gone through a few therapies and that the transplant decision, that risk of transplant is worth the treatment. And so while we are often talking when we meet somebody about what's likely to happen with your disease, you're absolutely right. It's very contextual. It depends on what your goals in life are. Also, some of our therapies are big burdens. If you've got low-risk disease and you don't need transfusions, and it might be years before it evolves into anything more significant or that you need a transfusion, I'm only going to be a burden on your life by making you come in every week for an injection or starting you on a chemotherapy. Or if I go to transplant, I really derail life for a little bit because we're trying to give you a new bone marrow. And so I think that there is these tools really help us talk about disease and talk about what options are out there and frame what is likely to happen in the next 1, 2, 3 years. But we have to tailor treatment to each individual's goals, and what your overall goal is may be very different from another patient. You're absolutely right.
Great, thank you. Our next question is there ever a need for a second bone marrow biopsy?
Yeah, no, I mean, unfortunately, the bone marrow biopsy is still our best way to understand what's really going on in the factory. There have been efforts to try to use peripheral blood metrics to better understand changes in the bone marrow and to understand, is disease evolving? That's part of where molecular testing can help. But we really haven't gotten rid of the comprehensive data that a bone marrow biopsy offers. That includes the blast percentages. Cytogenetics tend to be better on the bone marrow, and molecular testing can detect small populations in the bone marrow that we often miss if we just do it on the blood. And so often I'll make sure that the initial bone marrow biopsy is of good quality. It's a sample out of a space in the bone, and sometimes the quality of that sample is poor and may not be a reliable measure of the exact disease. And so sometimes even at initial diagnosis, we're doing a second one to figure out, are we actually dealing with this type of disease, and is the risk accurate? But over time, you're right, there are second and sometimes third, fourth bone marrow biopsies. During treatment, we often rely on bone marrow biopsies to assess response. So over the course of time, if we need to understand what is actually going on precisely in the bone marrow, it usually does involve a reassessment of the biopsy.
Great, thank you. Our next question is, if someone has a normal karyotype on their cytogenetics report, would that fall into the good or the very good category in the IPSS-M?
Yeah, so the IPSS-M is a big change in our risk scoring, mostly because it incorporates this really growing understanding of how specific point mutations in disease play a role in prognosis. That said, it included a lot of patients, but not as many patients as were included in the IPSS-R. So the IPSS-R was our second disease risk prognosis score that was widely used. IPSS-R is a little over 10 years old at this point. And the IPSS-R, just as an example, used about 9,000 patients, whereas the IPSS-M used about 3,000. And so the cytogenetic information is actually much more comprehensive from the IPSS-R. And in the IPSS-M, we still use the cytogenetic classifications that were identified in the IPSS-R. And so that puts, for instance, normal karyotype, it still lives in the good cytogenetic category rather than the very good cytogenetic category. So the cytogenetic groupings that are used for those two prognostic scores are actually the same between the IPSS-M and the IPSS-R.
Great, thanks. Our next one is, how does CCUS fit into the MDS groups?
It's an evolving question. That's a great question. It is a big advantage that we know how to use sequencing much more. We know how to find small alterations in these genes, and we can find them in disease states, but then we can also find them in people who may have a precursor state or may have a low blood count for some other reason. It has helped us make diagnoses of MDS. When you have a lot of blasts in the bone marrow, or you have ring sideroblasts, or you have some other marker that says this is clearly clonal and this is abnormal bone marrow, makes that easier. And then there gets to be this gray zone where it's not overtly dysplastic, and you have a low blood count. Often people, CCUS may have other comorbidities and can be hard to exactly distinguish from MDS. And I think it's an evolving category of disease. It often does not require therapy, and there are a lot of overlaps between CCUS and low risk MDS. And as we've tried to figure out how to think about CCUS, particularly for clinical trial design, it's you want to make sure when you're doing any intervention, right, that you're treating the problem. And so CCUS and low risk MDS, you're often trying to exclude secondary causes of low blood counts. And in many ways, the outcomes and the clinical trajectories of patients with CCUS are very similar to patients with very low risk MDS. And so one proposal has been, maybe we should merge these groups if we're trying to identify, anemia therapies, maybe we can include both. But it is still a bit of an evolving entity. There have been new risk scores. We've also learned a lot about CCUS. There are some subtypes of it that really will evolve more over time. And there's new risk scores that can help us identify those. But there are many subtypes of CCUS that, we can identify, but that the vast majority of people will coexist with for many years. I think that the other thing about CCUS and low risk MDS is that because these are entities that most people will live with for a long time, they can cause other problems. In particular, cardiovascular disease risk is higher in patients who have CCUS and low risk MDS. And why is that? Well, you live with this clonal disease. It seems to increase the rate of atherosclerosis. And so cardiovascular disease does seem to be increased. Now it's a modest increase, but often when I'm meeting somebody with CCUS or very low risk MDS, I'm mostly talking to them about how do we make sure the rest of you is healthy? How do we work on your cardiovascular health? There's a number of cardiologists now who have an interest in this space. And so some patients might see someone in that group. And so it's an evolving question of where CCUS lives, but it overlaps a little bit with the very low risk MDS, and increasingly is seen by similar disease groups like we see it here or precursor clinics around the country.
Great, thank you. The next question kind of overlaps with that. I know you talked about the risk levels for CCUS. They're wanting to know if there are similar classification systems for CCUS specifically.
Sure. It's that is still there. That's still working in progress. I think that CCUS is there are several proposals looking at large groups of patients that have tried to figure out the risk of them. One is the clonal hematopoiesis risk score, the CHRS, and that can help to identify the chance of the disease of CCUS progressing. There are a few other scores. It's still early in that field. So, as far as an IPSS or, looking at the WHO or ICC, CCUS is increasingly recognized, but as far as like risk scores, it's still a evolutionary work in progress. Personally, I tend to use the CHRS, although I admit that there are a few risk scores that are in development, but the CHRS has a nice little web app that can help sometimes in talking to somebody about, well, what's the chance that this is going to stay stable, or do we have to worry about this changing in the next 1 to 5, 10 years?
Great. Next question is 55-year-old Caucasian, recently diagnosed in the last few months with TP53 mutations and lucky to have multiple sibling matches for transplant. Does the high-risk variations typically factor into the decision to proceed with transplant by the hospital committees?
Also a good question. TP53 is a tough entity. Transplant consistently shows some survival benefit. And there are a few people who can have long-term disease control and, not relapse after transplant. It's a tough disease group. Not everybody, it's a minority who do well with all of the therapies needed to get to several, years out from the disease. In general, our institution does not, we don't exclude anyone from transplant for a P53 alteration. There is a lot of heterogeneity, variability of what P53 mutations look like. So if you're missing one copy of the gene, that's different from missing both. And there's some growing exploration of if we can get you into a better response, or should we be trying to maintain treatment after transplant to try to improve outcomes for people. And so, I think that while there is a lot of variation in practice, if we meet somebody with a P53 mutation, that in and of itself is not a reason that we would exclude them from transplant discussions. We transplant many patients with P53 disease. So I guess from a yes/no gateway, it's not really something that completely excludes someone. It is worth a discussion because it's a different course to undergo for sure.
Great, thank you. The next one is, why don't you use general anesthesia for the bone marrow biopsies? They hurt. why go through that instead of being knocked out seems kind of barbaric. It's
Sure.
tough. It's
Well,
tough.
I guess that varies a lot of who gets the bone marrow or how it's done by institution. Certainly a lot of variation in practice there. That's more, I guess, kind of dependent on who's doing it, and probably local hospital guidelines. We do try to we try to give some medication for our bone marrow biopsies. But I know that there's a lot of variation depending on where you're treated.
Okay. The next one is I am a layperson. My husband passed almost a year ago from MDS with TP53. When you speak of genetics, are you referring to heredity? Do I need to worry my two sons could possibly inherit MDS?
No, it's a great question and a big concern. It's blood cancers in particular are perhaps the area where our understanding of mutations have so altered our understanding of disease. And, so much so that when I talk to people about staging their disease, in a lot of ways, it's genetic staging rather than, in a solid cancer where you might say, oh, this is metastatic or this is stage 1, stage 2. Really, in blood cancers, we rely heavily on the mutations there to understand how the disease will behave. And so there are a lot more patients where, because what material do we use? We take a sample from your bone marrow and we sequence it. And we're looking mostly for mutations that are unique to the cancer cells, but not in the rest of the body. And so those are not inherited or inheritable. And we think of them as being acquired over your lifetime. And we use the term somatic. So, you live long enough under the sun or through exposures that gene gets mutated, and it's not something you got when you were born, and it's not something you can pass on, but it's unique to the stem cell, and that mutation over time can evolve into disease. That said, there are, I think that's touched a little bit on the DDX41 question. The more we understand about genetic predisposition, it's possible that 10 to 20% of MDS and AML cases have some link to of potential familial risk, so meaning inheritable risk. So increasingly, yes, when we find one of these mutations, we are thinking about whether we need to look for familial risk. And it varies quite a bit. So DDX41 is one. TP53, which you mentioned, is typically only seen in an entity called Lee-Fraumeni. And that usually has a pretty high rate of many cancers in a patient's family, if that is inheritable. There are others. RUNX1 can be familial or it can be acquired. CBP alpha can be familial or it can be acquired. A challenge is that many of these, it can be hard to know on just the first glance when we get that sequencing, whether you were born with it or whether this was something that you acquired in your lifetime and it's not something you pass on or received from your parents. One way to somewhat roughly tell that would be to see if it goes away. So if you treat somebody and the mutation disappears, that would be a sign that, it was only in those stem cells and not inherited. And that can be a general sense that it's not inheritable. I mean, you can't pass it on. But usually what you really need is more a test of something other than blood. So skin biopsy or some other tissue that's not blood, to be able to say, this mutation was only in the blood and it's not in the skin or other other tissues. And so, for instance, here, we work really closely with our genetic counselors. If we have someone where we think a mutation, was in that gray zone of could this have been inherited? Is this a risk for a family? We often talk to that patient and their family, and we may do testing. Typically, be the person with the cancer that gets tested. And so, I think it's worth bringing up with the doctor. It's definitely over the last 10 years, increasing understanding of the broad spectrum of potential contributors to disease risk. But I guess the other thing to remember is that the vast majority of people, it's not inherited. It's unfortunately something that we acquire with age.
Okay, thank you. Our next one is, I did not see any mention of SRSF2, CBL, or TET2 mutations on disease progression or response to therapy. Can you comment on whether there is research on these mutations?
Absolutely. All common mutations in MDS. And you're right, they haven't risen to the level of classification system, meaning that they haven't been become like a distinct entity in the ICC or WHO classifications. But these are very common mutations in MDS and mutations which we use to confirm the diagnosis, but also to impact prognosis. So for instance, that IPSS-M score that we looked at, web score, that uses SRSF2 and Sybil for prognostication. There are efforts to try to understand how to target these mutations. We are not at the point where we have a clear targeted therapy for them yet. There was an effort with TET2. It's involved with methylation, and so there were some efforts to try to modify that through high-dose vitamin C or through, it seems to associate a little bit with response to azacitidine. Similarly, SRSF2 is a splicing factor. There have been a lot of efforts to try to use that as a target. When you think about like targeted therapies that could selectively kill MDS cells and leave healthy cells alone. Those are still kind of in phase 1 settings. And so these are definitely on the top of our minds for where we can intervene. Getting targeted therapies into practice, we're still in the early days, however.
Great, thank you. The next one is, how is secondary MDS acquired from chemo and radiation staged differently from de novo MDS?
Also a great question. Also something that has recently evolved. When we had previously developed prognostic scores, the IPSS or the IPSS-R, those patients excluded really patients with prior therapy. So if you had chemotherapy, if you had radiation, these patients were not really included in the development of those risk scores. And so it was not known for a while whether they behaved the same, or if just by the fact that they had disease coming after prior chemo or prior radiation, were they really a different entity? And so when we did the IPSS-M, and actually a little bit before it, we'd explored this idea that, is your disease course driven by what you've experienced so far? If you've had prior chemo, does that dictate what's likely to happen? Or, is it actually, maybe it just matters what mutations you get. Maybe I had chemotherapy 20 years ago, and now I've just got an SF3B1 mutation. Is my disease really that bad just because I had chemo decades ago? And the IPSS-M included patients with therapy-related disease. And it does seem to be that the genetic composition, so the mutations that occurred, those dictate the course. Now, if you've had prior chemotherapy, if you had prior radiation, sometimes that is associated with having higher risk mutations, meaning mutations that don't respond as well to chemo or that tend to be associated with a faster disease course. And so there is some truth to this idea that a long time ago, people noticed if you had prior chemo and they got MDS, that seemed like it was a more challenging course. That may be really mutation dependent. So in using the IPSSM, you can include patients who've had prior chemo and radiation. I think, yeah, sometimes you will find still some challenging mutations present. But I have many patients where just because they had chemotherapy or radiation in the past, their disease actually still fits in lower risk entity. And we, now feel more comfortable with being able to say, we'll watch it closely, but, maybe we don't need to rush to more intensive treatment if it's lower risk.
Great. Another question is, what happens if you have characteristics of multiple subtypes? How do they narrow it down to one?
Sure. There is a bit of a hierarchy, and this is where our pathologists are very helpful. It's a bit of a cascade, going from blast count to genetic profile, AML defining mutations, and so there's a little bit of a hierarchy in which metric trumps one another. And so some of these have been around. So for instance, if you have a mutation in del5q, that has historically been a disease entity where you have a high platelet count, you only develop anemia, it tends to be lower risk. But there were some patients who would have additional alterations. And so we've known for some time that del5q alone, or maybe with one other minor alteration, that's okay. And that does follow that pathway. But when people have multiple alterations, then all of a sudden it becomes more of a higher, it doesn't follow the same behavior. And so there is a little bit of a cascade that your pathologist will do after they get the bone marrow and they get the cytogenetics and they get the molecular testing that helps to sort to a specific diagnosis. Because you're right, there are some overlapping features of all of these. And we use them a lot interchangeably, which can be challenging to follow. I think the final diagnosis and then the IPSSM risk score are probably the two main things that each patient should know about their disease.
Thanks. Next question is, I first had multiple myeloma for 21 years and 2 stem cell transplants. The MDS AML was identified in a recent biopsy. It showed TET2, 2 different TP53 mutations. My FISH analysis showed a 5q and 2 7q, currently on Vidasa. So will that work against having a stem cell transplant?
Yeah, no, sounds like you've done great with myeloma, and it's what we're also trying to do with MDS, change the disease. Those are tough mutations, but it's still in our case we would kind of see what the response was, and it doesn't exclude people from going through transplant. When I talk to people about transplant, I usually talk about two things. One, all of your body needs to be fit enough to get through a transplant. And an allogeneic transplant in particular, it's a big undertaking. So your heart, your liver, your lungs, the rest of your body has to be healthy enough. The non-blood compartments of your body have to be healthy enough. You have to, be able to move around and eat okay and get through the months of an allo transplant, which is, it's a big undertaking. We get people through it all the time, but it's a little bit of a mini marathon. And then the other component is making sure your disease is controlled. And why does that matter? Well, when we give a new cell population, we are suppressing it. So you get immunosuppression right after an allogeneic transplant. Even if just for a short while, it's still trying to prevent the new cells from thinking that you are foreign and causing something called graft versus host disease. And during that period, we are suppressing any chance that those cells have of targeting the MDS. Because we're immunosuppressing them, they cannot develop an immune graft response against the MDS cells, or it might be limited. And so when you transplant somebody, there's a window where they're at, we don't want their disease to come back before they've had a chance for the donor cells to start working. It's kind of how I think about it, I guess. And so some of the decision around timing of transplant, it's pretty clear we want to go early. It's important to know what kind of chemo they're giving for the transplant. Can they give the full intensity treatment, or are they going to have to give kind of a lesser intensive treatment, in which case, disease control and not relapsing during that first 3 to 6 month period matters. So I don't think a priori anything necessarily excludes people from getting to transplant, but those are the things we want to optimize when we're talking about transplant is, how are you as a whole? And then is your disease controlled enough? Do we feel like we're going to be able to get through a few months before we might have a transplant effect? And that varies also depending on what kind of transplant chemo and other things you're getting. So it's an important discussion, but, I think that for everybody, it should be a discussion, meeting with, in our case, I do MDS, and my transplant colleagues will meet people and talk to them as well. But having that coordinated discussion really is important, and understanding what you are undertaking.
Thank you. So we have a follow-up question to that. Is graft versus host disease a lifelong illness, or does it go away?
Sure. A lot of variability. There are some types of graft versus host disease that are acute and can be suppressed and go away and, don't leave any lasting mark. There are some that can be more insidious and hard to get rid of. There are some that might be, fairly mild in the end, but persistent and frustrating. Dry eyes or dry mouth that, is controlled but challenging. So it varies a lot. I will say that there are new therapies in graft versus host disease. Even in the last 5 years, there have been a lot of breakthroughs. And so, I think in general in the field, an encouraging aspect is that we've really been able to move the needle on a lot of things that were a challenge even 10 years ago. But there's a lot of heterogeneity. And I know that's a consideration for anyone who's thinking about a transplant and an MDS, with that being the main way to have long-term disease-free survival. It is, it's often a balance between, well, what would my life look like if I did a transplant versus what's my life looking like if I don't. But I think that there have been innovations for both directions. And I hope that in the next 5 years, we really continue to see some new treatments, both in MDS and then for those patients who go to transplant.
Great, thank you. We all are almost to the close of our Q&A, so if you have any questions, please type those in now. I do have a question about, so some of the reports that you get take a while to get back at diagnosis. Should they wait for all of those to come back before they treat?
It's a great question. Most of the time with MDS, so my practice, I try to wait. If I have somebody who has MDS, I will know their blast count pretty early. But molecular testing and cytogenetic testing may take 1, 2, 3 weeks. In general, any therapy that we do in MDS Takes a little while to work, meaning often 2 to 6 months of treatment to get a full response. You might see early responses, but it can take a little while to get a full response. And there are distinct treatment paths, depending on if there are high or low risk features. And again, that gets into that prognostic scoring system. And so I generally try to wait for all the data before I initiate any therapy, because I think that there is some advantage to understanding what your specific disease is and understanding how that plays into disease risk. The long-term goals may vary, but in general, MDS, unlike acute leukemias, unlike other more rapidly proliferating diseases, usually do have time to make a decision around treatment. Even patients I meet when they're hospitalized for a complication, because whatever I start will take a while, I usually try to get them over that initial hump before we get started on directed therapy, just because it will take a while for the response to happen. And so long way of getting back to the fact that in general, yeah, I try to wait for all the molecular and cytogenetic data before I finalize a treatment plan. Now, during treatment, you might not wait so long for each time point. Maybe you're just looking for one specific thing. If you're doing serial bone marrow biopsies, for instance, for response. But for that first decision tree and trying to figure out, well, what are we actually dealing with and what should we do for you? I do try to get all my comprehensive data back first.
Great. And then unless anyone has any more questions, this will be the last one. So I get questions a lot from patients on variant allele frequency and what that means. They see it on reports. Can you speak a little bit to that?
Sure. Yeah. I mean, the good thing in MDS is, and in blood cancers in general, we have far more information at our fingertips than we ever had before. Many things that are, early out of the lab or out of clinical research have now made their way as tools. They're, practically speaking, variant allelic frequency does not have a firm role in all clinical practice yet. How do I use VAF? It's basically taking a pool sample and then you sequence all the cells in that sample, and it tells you a percentage of each mutation. And so if you have one cell population where the VAF is read at you take a sample and it reads out a VAF of a mutation at 5%. It means that of all the cells in that tub, they sequenced everything, and 5% of those sequences read that mutation. Every cell in our body has 2 chromosomes. So if you think about it, that means that if you read 5% mutations, then 10% of the cells had that mutation, each of those cells having one bad and one good copy. And so you can argue, okay, of this little sample that I just sent off and had sequenced, about 1 in 10 of the cells have this mutation. So I think it gives me a sense of what is the clonal composition, what is making up the MDS. Most of the time, by the time someone has MDS, there's at least one mutation in the 40 to 50% range, meaning almost all of that sample, that blood sample that you sent off, or that bone marrow sample that you sent off, has one copy of the mutant, one copy of normal. So 50% means that roughly 100% of that sample is derived from that mutated population. And sometimes we are trying to learn how to use it. For instance, can we see those mutations go away? Can we see that VAF percentage drop down with treatment? But as far as consistent use of VAF in clinical practice, it's still evolving. I think we don't have gold standards, nor do we really have a perfect understanding of what cutoffs we should use. But that's the general sense of it, is it gives a little bit of a understanding of the composition and the relative proportion of each mutation that you might find.
Great, thank you. So we've had several thank yous in the comment boxes. We do very much appreciate your time. Any last comments from you before we wrap it up?
No, I mean, I guess thanks for joining me today. I appreciate you taking the time out of your Saturday to talk about MDS. I think that we've made a lot of advances in MDS, and we're much better at understanding very nuanced subsets of disease. And I think that's good and bad. We've made it a little bit more complicated, but it's important that we have a good language to talk to each other about our disease. And so how we communicate with one another. The MDS clinician community is a small community. We work well together and are all trying to do best for our patients. There's a lot of new therapies, and we're trying to understand within these subtypes who responds best to therapies. And so if it's important to know kind of how your disease is named, because that helps you communicate with your doc. But at the same time, that's just the starting point. Treatment goals, exact therapies that might be best for your mutation, all of that is a really personalized discussion. I think that, I hope that in the future we have just more improvement to come in how we can tailor our treatments to our patients. So thanks very much for joining.
Thank you. So thank you to Dr. Brunner. We're very happy to have him today. Also, quick shout out to our sponsors. So they are AbbVie, Bristol Myers Squibb, Servier, Taiho Oncology, and to VJ Hemonc for making this possible. Feel free to reach out to us at the foundation. You can reach out to myself or Janice directly if there's any resources that you need or any help that we can provide. Otherwise, have a great rest of your Saturday.